So moving on to our next session, which focuses on the role of religious institutions and faith-based organizations in supporting faith-based health systems. Across traditions, many religious institutions have increasingly recognized the critical importance of WASH in healthcare and are taking meaningful action to address these needs. In this session, coming up, you will hear perspectives from institutions including the Anglican Church, the Muslim World League, the Methodist Church, the Salvation Army, reflecting the growing breadth of faith engagement in this area. But first, reminding us that yesterday we had the blessing of a message from Pope Leo in support of our work here. And in the spirit of this being a multi-faith and ecumenical occasion, we're honored to share a special message marking this occasion from the Church of England. Please join me in viewing a welcome video from the Archbishop of Canterbury, Dame Sarah Mullally, who was recently installed on March 25th, and reminding us that she has also served as the Chief Nursing Officer of England and is most familiar with our issue here today. If we could have the video, please.
On behalf of the Anglican Communion, I'm glad to offer my support for this multi-faith convening on water, sanitation and hygiene in healthcare facilities in Rome. Across the world, Anglicans are engaged in healing ministry through hospitals, clinics and community health, often in the most challenging contexts and alongside partners from many churches and faiths. I give thanks for this shared commitment and for the leadership of the Vatican in hosting this gathering. As a former nurse, I know that clean water and good sanitation are essential to safe and effective healthcare. I'm therefore encouraged by the work already underway to strengthen Anglican health facilities in several countries, with more to come. I encourage all across our communion to support this vital work. I pray that this meeting will help extend these efforts, bringing lasting improvements to many more communities around the world. Following the example of Jesus Christ, we are called to a ministry of healing. Thank you for all that you are doing to make that calling a reality. On behalf
welcome this statement from the Archbishop, and we appreciate the commitment We very much appreciate the commitment of the Anglican Communion to advancing this initiative by co-convening the meeting and by having its senior representatives here with us today. It's now my pleasure to introduce the chair for this next session, our colleague Mark Brinkmuller, a longtime member of the organizing group and principal with the Assisi Strategy Group. Mark is going to guide us through the next discussion. Mark, the floor is yours.
Thank you so much, Jean. It's an honor to be here, truly, especially after yesterday. Everything that was said and committed to and discussed. So it is to use an old Catholic word, it is edifying to be part of this. Let me just say good morning, buongiorno, assalamu alaikum, pax et bonum. We're excited today for this panel to talk about the role of religious institutions that have water, sanitation, and hygiene programs implemented around the world. And this is in addition to, these are the kind of institutions or the organizations that have both a spiritual message as well as a public good message for all of us on water, sanitation, and hygiene. And that's somewhat different than when I was part of an NGO or part of a government agency or something like that. To have those things tied, it's kind of like heaven and earth gripping each other and bringing that link in, which I think is very powerful and special. We want to explore that today. And then throughout the rest of the day, when we're talking about other sorts of organizations that do water, sanitation, and hygiene in healthcare facilities, that we'll see everyone has their gift. Every kind of group that comes in has their special gift, and we'll explore those today, and I think in the full day. Is that close to correct, Jean? Amen. Thank you. So in terms of today's order, and as I say, I want to bring people up to the podium to speak, we're going to start with Bishop Michael Beasley will speak and give us a few remarks and words from the dais here. Then we'll have His Excellency Dr. Abdulaziz Sarhan, the advisor and coordinating commissioner of the Muslim World League to the Vatican, give his remarks. Following that, we'll have Joanne Beal from the Salvation Army, and then Misha Shadre, United Methodist Church. Is that acceptable to the team? I'm usually pretty obeying German, so when I deviate from what's on the screen, it gets me a little nervous at times. We're not supposed to do that. Anyway, so if we could bring the panel up on stage and then in various places. In this session, what we hope to cover, the value of religious institutions in providing water, sanitation, and hygiene in healthcare facilities, their own and others, and supporting others around the world together, kind of in solidarity of all of us in the room. The progress made in WASH within the groups that have been part of this effort and have made commitments previously. And so we'll hear a report on that progress. And then next steps and commitments to scaling up in the future from the people and the people on this table. Again, are we good with that? It's a little early. I want us to kind of be responsive and be engaged in what we're doing today. It's, as I said, it's such a blessing to be here. So first, let me turn to Bishop Michael Beasley, Anglican Church Bishop of Bath and Wells.
Good morning again. It's lovely to be able to speak to you a little bit about the Anglican Communion and our involvement in this work. Perhaps I need to start by saying, what is the Anglican Communion? We are a communion made up of 42 autonomous provinces and 5 extra provincial areas that are all around the world. We're in 105 countries, and we have somewhere around 85 million adherents. The inherited mission model of Anglicans can be described as primarily churches and their worshipping communities, hospitals and schools. We have inherited a lot from the past. So, for example, in India, there are 169 Anglican hospitals. But new facilities continue to be built all the time. So last year I was in Zambia and was seeing a brand new health centre that a local bishop had sponsored and got behind in their area, and that was newly opened. In many places we continue to be major providers of health and education, and that happens all around the world. So, for example, in my own diocese, church schools educate 60% of the primary school children of our county. So now, to move to the areas that we're discussing during our meeting, and I want to start on behalf of the Anglican Communion by saying thank you, because we are the beneficiaries of all that was reported yesterday. This renewed focus on WASH in healthcare facilities. It was great to hear yesterday about the work in the 150 facilities that was being described. We are underway too, working in 3 provinces. We're undertaking this work in Zambia, in Bangladesh, and the Philippines. We're supported in that work by an Anglican mission agency, USPG, and my colleague Duncan, who's head of that agency, is here. And And what we're seeing in the different countries where we're operating is that this is enabling partnership with many different actors and organizations, all pulling together to improve WASH in healthcare facilities. If you want to see in detail the work that we're doing, then it's all collected together on the North Carolina website that we heard about yesterday. So what are our next steps and our commitments? I think for me, yesterday was a terrific day of learning. And it helped me appreciate that to take this work forward, that lots is needed. We need evidence. I was so struck yesterday about what was said about how improving WASH in healthcare facilities directly impacts on maternal and neonatal sepsis. We need to make the moral argument. What we're about is about the dignity of every human person, and this is based in our values. We need knowledge. We've been hugely grateful through this initiative for the technical input that we've been receiving in the different countries where we're at work. We know that we need more resources, both financial and human, if this work is to take shape. And I thought most interesting yesterday were the questions raised about mentality. How do we address the issues of ownership, accountability, and participation that are going to be needed if this work is to be effective? So what are our commitments? I am one of the co-conveners of the Anglican Communions Health and Community Network, and we shall continue to be active in this area. Also, this July, we have the 3-yearly meeting of the Anglican Consultative Council, which brings together Anglicans from all across the world to make decisions about the future. And I'm looking forward to showcasing the work of the work that's going on at that meeting to seek to engage more provinces. The particular gifts that perhaps Anglicans bring to this is we are a structure which particularly emphasizes decentralization. We're a family of sibling churches. We bring particular gifts, we hope, in relationality and bringing together people in partnership. And everywhere, as we heard particularly yesterday from the sisters, I think we too would share in the asset-based approach that they exemplified. And all of that, we're looking forward to the common endeavor that we share in. Thank you very much.
Thank you very much, Bishop.
بسم الله الرحمن الرحيم.
In nome d'Allah,
of the compassionate and merciful. Praise the Lord. Before I read the text of His Excellency, Dr. Abdelaziz, he wanted to talk briefly before he reads this.
Here today. It is my pleasure to be with you. I want to tell you something before my colleague, talked about my word here. It is very important not to work for wash or for water or for cleaning or for whatever. The very important thing is to be here because you are caring about humanity. This is very important thing. The goal, then the work. and you are here for both, to achieve the goals and work. Thank you.
Now I'm going to read the brief speech of His Excellency Dr. Sarhan, International Delegate of the Muslim World League. In the name of Allah, compassionate and merciful, praise to Him and peace and blessing of Muhammad our Lord and his family and his companions, and on Jesus our Lord, sons of Mary, and all the prophets of Allah, nobody excluded. Dear brothers and sisters, I wish you a day full of blessings and joy. I am Dr. Sarhan, Special Counsel Delegate, International Delegate, and Director of the Italian headquarters of Muslim World League. I bring to you the greetings of His Excellency Sheikh Mohammed Botarin Karim Aysala, Secretary General of the Muslim World League, and with his best hopes of success in this endeavor. It is an honor to be here today with you, and I thank the organizers and all those who are here to this gathering. The Muslim World League is the largest Islamic non-governmental organization in the world that works to the benefit not only to the Muslims but to entire humanity without any distinction. We are present in many countries and many areas of the world to carry out healthcare projects and education fields, social activities such as hospitals, schools, mosques, wells, and sustainable initiatives. We support 90,000 orphans around the world, and we help 100 million people around the world, and also through the building of wells in the most needy areas. The League supports and promotes this wonderful initiative, and His Excellency, being the director of the headquarters in Italy, commits himself in conveying news to the General Secretary, supporting and asking collaboration and support to your initiative, WASH initiatives. Furthermore, our help is offered in respect of human dignity and the attention and necessary so that the gesture can console the dignity of human beings. Thank you all. Peace and blessing of Allah and His mercy on all of you. Thank you.
Thank you very much. Thank you very much, Your Excellency. Grateful. So following that, if we could ask Joanne Beal, International Community Development Lead for the Salvation Army, please.
Thank you. And thank you for this opportunity to share with you this morning. This topic is deeply personal for me. Like actually a few of us in this room, I'm a water engineer by training. I've spent 20 years working in the WASH sector. And so like many of you, I've seen firsthand the consequences of poor WASH standards in healthcare settings. The Salvation Army itself was founded on social action and care for the poorest of the poor. And this is a theology that continues to shape how we operate as a global church today. In my role with the Salvation Army's international headquarters, I have oversight of an incredible portfolio of projects which operate through bilateral partnerships between our fundraising and our implementing countries. The Salvation Army is present in 134 countries around the world. Just to give you an example, in 2025, our new funding commitments amounted to around $27 million, which will impact over 1 million people in 86 countries. Our work is extremely broad, both thematically and in the scale at which we work. While we do manage some institutional funding for larger programs, especially in things like the WASH and agriculture sectors, some of our most holistic and impactful programming is small and church-led. These churches have been in the same communities for far longer than any international NGO has been in existence, building relationships and trust and becoming integrated parts of these communities. Though I do realize the irony of talking about longevity in Rome, surrounded by the Anglican and Catholic churches. Salvation Army is only 160 years old. The Salvation Army has 119 healthcare facilities in 18 countries, many of which were established decades ago in response to local needs. The Salvation Army, as I've said, reaches the poorest of the poor, so many of these healthcare facilities are in extremely remote and rural settings. I think someone mentioned this yesterday as well, that churches are often providing services in places that others are not willing to reach. Today, caring for these facilities creates some tensions. As a global church, we balance competing priorities: evangelism, social services, pastoral care, emergency response, and this broader community development work, whilst also trying to steward these complex institutions that must meet national regulations and global expectations. But we are clear on this. Where the Salvation Army provides healthcare, it must be safe, dignified, and credible. Access to water, sanitation, and hygiene is not an optional upgrade. It's foundational to our witness and to the trust that communities have placed in us. We have to say that up until now, our work on WASH in these facilities has been a bit ad hoc. So over the last few years, we can talk about an example in Zambia, where we have a major hospital, a nursing school, and a biomedical school. And we've done a comprehensive $2 million upgrade there to the site's water system. And so now that whole site has access to safe, clean water. In Papua New Guinea, we've given rainwater harvesting resources and access to 23 healthcare facilities. Boreholes have been constructed at 2 healthcare facilities in Ghana. Sanitation facilities were built at a clinic in Kenya. And in Malawi and Zambia, our community WASH programs have extended to support health facilities operated by local government. But in 2025, the General of the Salvation Army approved a set of guiding principles for Salvation Army health services, which sets clear expectations across all of our facilities, including infection prevention and control, regular assessment, appropriate governance, and ensuring sustainable operations. Strengthened WASH systems are essential to delivering on these principles. So building on this, we are now launching a 3-year organizational focus on WASH in healthcare facilities from 2026, from this year, to 2029. Our aim is to move from commitment to implementation in a more structured, more accountable, and more evidence-led way. And this meeting here in Rome has been a really helpful catalyst in finalizing this plan and spurring us into action. So our first phase, which is already underway, focuses on global mapping and assessment. We're using the WASH Fit tool and rolling that out across the countries where we have healthcare facilities, supported by training for our in-country health teams. And just a shout out to Colin McCubbin, who's here, who helped us write some WASH training materials a few years ago, And one of those modules is specifically on WASH in healthcare facilities. So we have access to that for all of our staff wherever they are. This mapping and assessment process will generate a global baseline, some facility-level improvement plans, and a consolidated overview of the needs and priorities. We're hoping this approach will allow us to move beyond our previous ad hoc interventions and to engage more strategically with funders and partners. By the end of 2026, we expect to be better positioned to mobilize resources, prioritize investments, and set clear targets, working towards an approach that sees funders coming together under one centrally coordinated program. This is actually a new way of working for the Salvation Army, but it does seem to be generating interest amongst our funding and our implementing countries. By 2029, then, we're working towards outcomes which align with the global benchmarks: comprehensive assessment coverage, improved access to basic water and sanitation services, universal hand hygiene, and strengthened waste management across all our facilities. Plus, of course, a plan of how these investments will be cared for to ensure that they last. We recognise that many of us here today are on similar journeys, and we therefore want to offer this not as a standalone commitment, but as a contribution to a shared faith-based effort, taking responsibility for these things that we've inherited and ensuring that they serve life, health, and dignity for generations to come. We look forward to continued dialogue, shared learning and collaboration, and to standing alongside others as we kind of translate these shared commitments into sustained improvements in healthcare environments. Thank you very much.
Misha, would you like to take over the mic and please share?
Thank you, Mark. It's an honor to be here today, standing on the shoulders of giants and on the shoulders of a 2,000-year-old institution. As Joanne stated, thus with the Salvation Army, the Methodist Church is comparatively quite young compared to the Catholic Church. But I did appreciate yesterday that Sister Alessandra had mentioned that on Isola Tiberina, down the river, there is a hospital next to a church. And wherever historically Methodist missionaries have planted their feet, and eventually a church, a health facility or an orphanage or a school were always sure to follow. The cornerstone of Wesleyan theology within United Methodism is that we want to extend and expand healing ministry to all. That is actually the motto of one of our health facilities. It's a common motto across many of them, particularly recently when I visited Sierra Leone at Hatfield Archer Memorial Hospital in Rotafunk. So, what does this look like in practice for Methodism, United Methodists? The central governing principle, the Wesleyan principle of connectionalism, is what is sort of the modified episcopal polity under which Methodism writ large, but the United Methodist Church in particular, organizes itself around. It is the organizing principle of our church. What this ensures for us is some level of an organizational structure. Our churches are all connected to one another through a hierarchy, through an episcopal area. There's a form of governance through the bishops, district superintendents, and over 132 annual conferences around the world. What it also allows, most importantly, is shared resources in ministry. So when churches are able to support projects through this connectionalism that they otherwise would not be able to do individually. If they are not able to afford to do so alone, the Methodist Church at large can step in through the general agencies, one of which I'm representing today, the General Board of Global Ministries of the United Methodist Church, under which, sorry, that's a mouthful, under which is housed UMCOR, the United Methodist Committee on Relief, which is the mission relief agency of the United Methodist Church. Connectionalism also allows a relational focus. We emphasize our shared identity, our mission. We communicate between ministers and lay people across the denomination. And then, of course, finally, it allows for some level of theological unity. It reflects our belief in a united church rather than separate, independent congregations. So why did I just launch myself into this sociological study of the United Methodist Church? Why do we care about this? Well, because of how well it places United Methodism in terms of our ability to accomplish WASH goals. Our WASH interventions are able to leverage church-wide resources rather than talking about discrete individual projects. When connectionalism is considered the heartbeat of the church, and what that also means is that WASH can also be the heartbeat of the church. Many of our health facilities, particularly those in Africa, are over 100 years old. Methodist missionaries set foot there, built a health facility. Some of them were left to languish, and the general agency would step in and revitalize that health facility. Many of them have health personnel whose salaries are paid for by the general agency. And so many of these health facilities are located in places where the Ministry of Health doesn't even have a presence. So what that means in practice is that Methodist churches are the institutional foundation for health in many communities. It's not uncommon when I go into the field to find a Methodist church, a Methodist school, and a Methodist hospital. And everyone in the community, Methodist or not, will attend those three things. Those form the lifeblood of that community. So you have communities, for example, in Sierra Leone, where there is a health facility. Across the street is a school where parents send their children. And then near there is the church, where on Sundays everybody goes, attends. This institutionalization is what has enabled us to do some pretty significant work in WASH. It has also allowed us to make a much greater impact in terms of our targets. There's more recently, or last year at the previous gathering, we had convened a community of practice. And you'll hear more about that later today in one of the later sessions, but one of the biggest I would say, developments to come out of that community of practice is we had gotten connected with Ruth Gemi at HAP, who's here in the audience, as well as Lindsay from UNICEF, Lindsay Nofton, who is unfortunately not here today. And they were able to help us develop and train the WASH Fit tool for our health facilities in Sierra Leone and Liberia. And through this work, we were able to identify all of the gaps that exist in our facilities and to be able to assess them and then work to intervene to address and close those critical gaps. So more recently, within the last 2 months, we developed about $800,000 worth of an $800,000 worth proposal to be able to close those gaps. These run the whole gamut from improving boreholes and pump systems to social hygiene trainings. At one of our hospitals, we had built these, there was a drive a couple of years ago to create modernized toilet facilities, but we built the infrastructure, but we didn't do the social piece of, I walked into the room and, you know, the sink was broken because patients came from communities where that kind of infrastructure or those types of toilets or those types of sinks were not commonly used. And so addressing that social piece has also been extremely important. But this is to say that the UMC is able to leverage its whole network of resources in order to accomplish our WASH goals. What we have been trying to do over the last couple of years is to emphasize, particularly in the aftermath of COVID, IPC, reduce maternal and child mortality in our health facilities due to hospital-acquired infections, and to intervene in the catchment communities around our facilities to ensure that they are oriented around hygiene practices, and that our facilities can serve as a centerpiece for them when they need WASH resources. So this, I started this with a little preface on connectionalism. It's nothing new. It's just a modified Episcopal polity but it's important because it allows us to work together, to share resources, to share knowledge, and to benefit everyone near a Methodist church, near a Methodist facility, near a Methodist school. And it allows us to be in dialogue with one another. And of course, to extend, once again, the healing ministry of Christ to all. Thank you.
Thank you so much, all of you. We're very grateful, very grateful. Dr. Alisa, I'm sorry. His Excellency is offered also to answer some questions while he's here, either about the organization or about some of the work. And so maybe we should start there. There may be a time that you may need to leave, and so we want to respect that as well. But is there any questions maybe to start the question and answer session with that? Any to the Muslim World League, please?
If you don't have question, I have question. Okay.
Did I see?
You
Oh.
listen to my...
Oh, please, please.
Thank you.
Why don't you ask, please?
Thank you. My name is Jutta Himmelsbach. I'm from Germany, working for Miserio, which is a Catholic development organization in Germany. Thank you very much. I don't have a question, but I wanted somehow to underline what you said in the beginning, which touched me really. We are talking about infrastructure and how we can improve infrastructure and give evidence on infrastructure's functionality with our work or within our work. And you put it to a point. You talked about humanity and dignity, so our work should concentrate on putting the human being in the center of our interest again. And that really touched me, and I just wanted to repeat it somehow with my own words. I'm sure I'll take it as a takeaway. Yesterday I talked about peace and how to build up peace from the roots on, so it's about creating relations and understanding each other, and you being here for me was one of those signs that we, with a common interest, should move somehow closer together and concentrate our work, focus on human dignity together.
Thank you so much.
في الحقيقة كلامك أيضا
le vostre parole
Your words touched my heart. I wish that by the end of this gathering, we will get out of here achieving the objectives of this meeting. I also hope that by the next meeting, it will be organized by the Muslim World League. In the Muslim World League, we are at the service of all projects that serve the human being. Thank you.
Thank you for being here and taking questions. My name is Steve Werner. I'm here representing Rotary International. But for any of our organizations, can you tell us practically and specifically how we can engage with your members so we know how to follow up this meeting?
The Muslim World League plays a pivotal role in this sector. We have offices in the vast majority of the countries across the globe, especially in Africa, Asia, and Asia. I was translating and I could not translate, so the interpreter is saying that he could not translate the end of the question. Anyway, we are all on the same journey and we all follow the same footsteps. Next time, we hope that we will also Arabic simultaneous translation. Our office is in Via Salaria in Rome. It's not too far from here. So if you wish to visit us, you're more than welcome until tonight, because then His Excellency has a flight back. We have a short video that shows the activities of the Muslim League and the works of charity that it's providing all over the world. And our aids are given to all humankind with no distinction of ethnicity, religion. We do not only provide aids to the Muslims, but to all. And this is happening in all the places in the world where we intervene. Thank you.
My name is Peter Fant with WEFTA, and similar to Uta here, I wanted to make a comment that we work in Tanzania with the Daughters of Charity, and the engineering company we work with has both Catholic and Muslim engineers. And the Muslim engineers understand the community as good or better, certainly better than I understand it. But we really appreciate their work, and we call each other brother, you know, as we do our work with the sisters. So thank you.
Amen.
I thought the battery is out. ترجم يا دكتور قل له نحن أيضا نشعر أنه لا فرق بين عرب أو مسلمين أو يعني غير مسلمين كلنا نحن إخوان.
In fact, we don't see any difference between Muslim or other brothers. I mean, we are all brothers, so we don't see any difference ourselves. So.
Yes. Thank you. We'll say, Dr. would like to leave. His Excellency would like to leave now and go on to his next meeting. Can we all please give him a resignation? I'm also particularly grateful to His Excellency for coming because we've been trying to reach out for a while now, but it really came together this week. So it was very fortuitous or blessed or any other number of ways we want to think about how this came about, and he was able to come on this day and be with us and be a blessing, I think, to all of us. Do you all agree? Yeah? That's a little weak. You all agree? Yes. Yes, amen. Good, good. Now, let's continue the question and answer, I think, with the rest of the panel. Anyone has any follow-ups or others? Did you have a hand back there up or no? I thought I saw a hand.
For the lack of others jumping to their feet. Morning, my name's Duncan. I'm the other kind of official Anglican representative here. I know there are a few closet Anglicans in the room as well. And I just thought I'd make a couple of comments about different churches have different sociologies, as we've heard. And if you're outside of that, how do you navigate different churches, I think is possibly an unspoken question in the room. So I just want to say a quick couple of things about the Anglicans. We are very dispersed. We kind of look a bit Catholic, and it's wonderful to be here with the Jesuits. My organization is a missionary organization. We were founded in 1701. We're kind of Jesuit light, if I can put it like that. But we will be, on the Anglican side, USPG, which is my organization, will be the kind of coordinating agency for trying to roll out WASH. And we're very much looking to the Catholics and others on how we do this. So I think I just wanted to say to anybody in the room who is tempted to walk a little bit of that journey with us in any capacity, do come and talk to me and I can take us through that. We've done a few pilots over the last year or so, and there's 2 or 3 things that have come out very strongly from that. One is we can actually be quite nimble, which slightly surprised me, and get things done quite quickly. So that's worth knowing if you're interested in engaging. The second is quite a number of our bishops and leaders are actually very switched on in this space, particularly a number of African bishops are very switched on. So there's some good, strong leadership and some good models already existing out there. And I think the third thing just to say is the potential is massive. We're working 165 countries, 85 million people. This is a big church. It's the 3rd largest communion. So please, if anybody's interested in engaging and getting involved in that, do kind of come and talk to me. My role is I am not the expert. I don't do the technical stuff. I'm, I think, what they called earlier, multilateral player. That is, I kind of go across everyone. And I'm the person with the relationships with the Anglican Communion. So, and I have to say, I think we're in a position where we can get things done. So if you're at the more technical end or perhaps a donor and want to know, how do you get things done in the Anglican Church, please grab me over coffee. Thanks.
Amen. Thank you so much. Bud?
If I might just quickly, Bud Rock, one of the co-organizers here. If I could just quickly put a small connection between the last comment and the comments that preceded that. I was particularly taken in the Anglican work about the programs that were initiated in Bangladesh. In Bangladesh, there is a small presence by the Church of England, surrounded by a substantial presence by the Muslim community, of course. And it was indeed the Church of England's representatives there who said, let's make sure, as we work to improve those Anglican facilities there, that we are also improving Muslim facilities at the same time. So it then presented us with the option to reach out and help encourage that interfaith connection within the communities themselves. So the fact that we're even thinking of that and recognizing it, I think when our facilities recognize their place in the community, they can also recognize what they can do as they improve themselves that will also build bridges with the rest of the faith community and beyond. So I applaud the Anglicans for taking that initiative from the start. And I hope we see more of that. I really do. Thank you.
Great.
Thank you. Rachel from Tearfund again. A question for Bishop Michael, I think. So Tearfund is in Burundi, and we're working in one Anglican diocese where the bishop is really great. He's really on board. The community have come together. They realized they didn't have a health facility. They had to travel a long distance to get to the local health facility. So they worked with the government. The government agreed that they would provide staff at the facility, but the community actually constructed this amazing health centre. They slightly overlooked the fact that they still had to go all the way down the valley to get the water. So we're talking with Jason and colleagues at Amazi Water to see how we can get over that particular hurdle. But I just wondered, that was so dependent on that one bishop in that one diocese. So I just wonder, how is there, with your network, is there sort of standards that all the different dioceses would be expected to work under, or is it very sort of dependent on the local bishop? We also found that with the Catholic Church back in the tsunami response in South India, where we worked with the Catholic Church there, and some of them, the leaders there, were absolutely amazing. But yeah, it seems to be quite dependent on individuals.
I think that's probably true. I think within Anglicanism, what we see is there is a huge power of example. So that often where a good example is seen in one place, then it can readily be adopted in others. It can be tempting to say we should have a common standard and that everybody should fall in behind it. I think our experience then is that then diminishes ownership. So I think that's why the power of example for me is particularly important for how we go about our work, and the kind of way that happens within the polity that we have. So I think what we can do together as a communion is be really effective in telling great stories and making the great case that's been made here, and then to see that picked up by increasing numbers of bishops in different parts of the world. So not about water and sanitation, but for example, in southern Africa, there's a whole nexus of bishops who work together on malaria control. And that's been really, really effective but it's not been through any bishop being told by anybody else that they need to do this work. They've seen the power of example, they've been inspired, they're getting behind it together, and they're making an enormous difference. And I think it's that kind of way that we find it most natural to work.
Please.
Thank you so much. Testing. Thank you so much for that observation. In Burundi, there's the power of example, and then there's leading by example as well. In Burundi, we actually have our Methodist Health Board, the United Methodist Health Board in Burundi, actually has a memorandum of understanding with the Ministry of Health for cholera response. So our Methodist Health Board in Burundi actually advises local hospitals, Methodist or non-Methodist, to lead with cholera response protocols. We talked about standardization. I think the work that we have done in cholera response and response to disease outbreak for waterborne diseases in general had so impressed the Ministry of Health that they had negotiated an agreement in which members of our health board would go to local facilities, specifically the one off the top of my head, Prince Regent Hospital in Bujumbura, and provide the technical advice, the expertise, the training, the protocols necessary to provide effectively counteract seasonal cholera outbreaks in the area. That is, I think there's the power of example, but there's leading by example too, and I think that's super important for our work specifically and the work of Methodist health facilities in the area. So.
Can I just add as well?
Please do.
Because I think this is a really important discussion about actually what the boundaries of our roles as mostly kind of international level positions can do, and actually where it's got to be on the ground that these decisions are made. And from my perspective, I can kind of coordinate funding, which is an incentive. Like if we do it as one big group, we're probably more likely to be able to leverage some interest from funders. And we've got guiding principles, but none of that is a mandate. And I think what I would love to see is that the kind of next meetings that come from this are regional meetings, where what we have the power to do is put you in touch with colleagues in those 134 countries, and you'll have colleagues in those same countries. So how can we make those partnerships work at a local level so that these kind of mobilization discussions can happen actually where the decisions are being made?
Can I just come in as well? I think, Joanne, what you had to say about the Salvation, some of the Salvation Army tools, I think could be really, really helpful to us. That kind of very light, if I'm correct in what I heard you say, those quite light touch assessment tools, which are going to be much lower cost, but to implement more widely, they could be a really effective way of advancing the conversation, I think.
Yeah. Please.
Okay, there it is. Morning, everyone. Parvin Gallo with World Vision. So I think just given the nature of the panel, His Excellency has left, but I think just the interfaith element to it is something that I was thinking about in terms of maybe it would be great to hear, your experiences, successes, examples at the country level, regional level, insofar as interfaith platforms, because I think we already got an example of working in very diverse contexts where we are having, as it were, to work with faith leaders from different communities. Are there some examples or great examples that we can share of what's working and maybe learning emerging from that?
Go ahead.
So, in several countries, off the top of my head, Ivory Coast, Sierra Leone, the demographic composition of the patient load at our health facilities is predominantly Muslim. In Sierra Leone, in one of our facilities, I think it was like 45% of the patients were Muslim. So what that looks like in terms of care and service delivery of care is sometimes you have to be especially sensitive to whatever gender norms or propriety norms predominate, and so making sure that there's some level of cultural sensitivity when it comes to programming with among our health personnel is really vital. But also just basic stuff like make sure the food is halal, things like that are things that we have had to address. Methodists are not the majority in many of the places in which we operate. And the to all part of extending the healing ministry of Christ to all is extremely important. It's something we really try and underscore because of the fact that the patient pool is not all Methodist. Everyone is not on the same page, and what care looks like working and operating in those contexts is very different from place to place, and it's very context specific. And so we've had to make modifications when it comes to patient care to be sensitive to people's cultural backgrounds, their theological orientation, and so on.
Right behind you, ma'am, and then you. Go ahead.
Thanks. Yes. Good morning again. My name is Max. I'm working with UNICEF, more on community engagement, social behavior change at global level. And I wanted to actually ask a similar question about interfaith in the sense that, as you know, UNICEF plays an important role of convening multiple partners in countries, particularly on, for example, risk communication and community engagement when there is a public health outbreak, an emergency like cholera and so on, like Misha, you were describing in Burundi. So what are the let's say, coordination mechanism in which perhaps your organization could be or are already involved at country level, at regional level, at global level, or maybe there is a gap and we could try to come up with something to promote a bit more, again, closer coordination, bringing partners together. In UNICEF, we work a lot with Religions for Peace, Africa Council of Religious Leaders for Africa, Religions for Peace for Asia, which are interfaith platforms, but they're not technical platforms, right, to discuss, for example, about WASH in healthcare facilities. We could tap into those spaces, and I will discuss a little bit later, but I'm sure that you might have other ideas to, again, strengthen the coordination among partners. Because again, for an organization like UNICEF, it's very difficult to work with every single denomination that is in the room, for example. So what are the ways to bring more than one partner together? Thank you.
Terrific.
So we work through, and I probably should have touched upon this a little bit more significantly in my 2 minutes, but we work through Methodist health boards, primarily, especially in Africa. And these are boards appointed by the bishop. The board itself is appointed by the bishop, and then the board hires staff that operates out of a health board office, a Methodist health board office. And the health board provides supportive supervision for our network of health facilities in country. We don't have a health board in every country, but in places where Methodism has a strong institutional or other history, we have Methodist health boards. Burundi is one of those countries. So if a local Muslim council wants to have an interfaith dialogue or wants to coordinate care with our network of health facilities, the first place I would go is to the Methodist bishop, but the health board that operates within that country, that is appointed by the bishop and is attached to the Episcopal area and does the oversight, the supportive supervision, the service delivery, all of the pillars of the health system strengthening framework in that specific Episcopal area.
I think the point you make is very interesting, and I can see that it would be highly advantageous for a UN agency to have a kind of one-stop shop place through which to engage with all the different faith partners in an area. I guess the reality is I just don't think we work like that. That the strengths that faith actors bring are about being local, permanent. We're not going anywhere. We'll be there for a long time. Often the messaging where I think there is huge potential for engagement across faiths is around questions of values that engage hearts and minds in a way that the technical does not. and that together finding common action. But whether to say within a country or a territory there was one obvious place that could be gone to that would just connect to everybody, I'm not sure that's actually how it works, and therefore I think that would be a false promise if we said that was the kind of thing that we were offering. But I don't know what others would say about that as well.
Yeah, just to add that I think from my experience, it's extremely contextual, and it just seems to be different in every country, whether that's something coordinated at a government level or whether it's an NGO forum, and actually whether even at community level there's the desire to mix things up, or whether actually they want to have kind of separate ways of dealing with things. So yeah, I think it's a very hard question to answer as a general statement.
Bruce Compton with the Catholic Health Association of the United States, and I'm a member of the WHO Faith Network, which is for pandemic emergencies and pandemic preparedness. And I've never heard them talk about this particular issue at that forum, but it seems like this would be a very important issue for those kind of interventions. And so I just wanted to put that out there. It's happening, but it's very specific for pandemic and emergency and pandemic preparedness.
Good morning. Sorry, would you like to go ahead?
Why don't you go first and then we'll pass on.
Okay, I'm Malik Keita with Global Water Challenge. I just want to pick back on these different comments because I feel like it would be indeed very valuable to have some type of strategic coordinated effort. I know that it's not easy to do. Issues are very context specific, localized, as you've all noted. There is no one size fits all, and it's not easy to bring different actors together. But I do think that what the UNICEF representative said, I think it should bring us to reflect a bit on what would be the call to action or a commitment that can come out of this. And the way that I think about it that might be strategic is that rather than finding a localized alignment between the different faith groups, maybe it's more at the regional, continental, or global level that there is a commitment similar to the Vatican's WASH initiative. You know, why can't faith groups come together behind a commitment? You know, I think we're talking about 150 healthcare facilities through the Vatican's WASH initiative. Through an interfaith commitment, why don't we shoot for 500 or 1,000, you know? But in a coordinated fashion, in a structured, strategic way, and then work towards that. The Muslim, what was it? It was the, apologies, I'm just looking for the name. World League. The Muslim World League representative noted setting the goal and then the work. And just along those lines, I think that this could be a way to do it. Just wanted to share those thoughts. Thank you.
Sister, you wanted to speak?
Thank you very much. I just want to share on the community level the experience we have. I live and work in Burkina Faso, where you have almost 80% of the population who are Muslim, and then the rest of 20 will be between the Catholic, the Methodist, and other denominations. And I want to say that when we have a borehole in a village that has to be put in place, we have what we call a managing committee that have to see to what happened after the water, how the borehole will be repaired. There are things, and sometimes when it is, we have the funding opportunity, there is this also strategy to train the local people who can do the minor repairs for this borehole. And this committee is usually somebody from the Muslim community, somebody from the Catholic community, from either, like I said, we have the Methodists, we have somebody from there, and then you will have the chief of the village. So this committee kind of represents the different faiths, because yesterday we spoke a lot about ownership. Water is one thing that unites all faiths together, because the water is in the heart of the village, and the face of the water has no religion and has no faith, because everybody needs the water. So like this committee is kind of an interfaith committee, and I see it work very well in our situation. WEFTA spoke a few minutes ago. The person who supervises all we do in Nuna and with WEFTA is actually a Muslim, and is really doing greatly well. Thank you.
Anything else? Thoughts, questions? So in the purple and then the pink perhaps, and then we'll go back into the suit.
On the issue of coordination, I just wanted to say that maybe after tea, when we start talking about the role of Christian health associations, we might get there.
I was about to say the same thing.
And we were just about to say that, yeah, we don't need to reinvent the wheel.
Yeah, maybe just to also highlight some of the coordination mechanisms that already exist. So many countries have a national coordinating group on WASH and healthcare facilities. So I really encourage all of you working in countries. WHO, UNICEF did a survey last year. We found something like 50% out of the 101 countries have such a group. So at the national level, really encourage folks to get engaged with that group, because it's obviously the way to also connect with the ministries of health and the government systems which we're trying to influence. Super interesting on the WHO Faith Network. Happy to look into that and explore it further. And certainly in terms of the wider global work, yeah, I would love to see. I was just reading through all the commitments, very impressive, by the way, how we can better integrate these discussions into the wider discussions that are happening around WASH and healthcare facilities. So that's, I think both are probably important.
Thank you. I'm Waima Koka with the World Council of Churches. I will be part of the panel talking about the health associations and also networking, but without preempting that conversation, I want to speak to the place of UNICEF and WHO and the national level coordination. We usually have the theme of, or the approach of health literacy among the faith community. And what I see missing is faith literacy in the National Ministry of Health. So I would want to encourage UNICEF and WHO, and by the way, I was one of the people who really motivated for the establishment of the WHO Faith Network. I was pestering my colleagues at WHO. They wanted it to be informal, backdoor, small corner conversation. I kept pushing. We can't be informal. Let's formalize it. Talk to your superiors. Because it adds no value if we are just an informal, advisory, voluntary, no. So I want to encourage our UNICEF and WHO colleagues, especially at the national level. when there's leadership from the Ministry of Health, it makes the whole difference. The Ministry of Health should see value in the faith actors in their country. The Ministry of Health, with encouragement, support, nagging, and whatever it takes from UNICEF, from WHO, they can convene all these coordination mechanisms and leverage the strength of all the partners and the faith community so that their contribution is maximized. We have all the advantages or strengths which we all know about being rooted in the community. Many of the health facilities have celebrated 200 years anniversary. 100-year anniversary, like 20 years ago, they were celebrating 150 years. So very strong in the community. And all these are, I think there's a word, hitting below the belt, because they are left to carve out their political space, the acceptance in the community, while one speech from the Ministry of Health can make them move miles more than what it would take them for months and months to get some doors open.
Amen. Amen.
So I want to encourage, I think, more candid conversation with the Ministry of Health that there should be faith literacy and value for the health workers and the support of the faith communities. I think we can move faster than trying to do a bottom-up. Thank you.
Thank you so much. Quickly?
Just one final comment. Yeah, silos are the enemy. I know that there's been this tension, and I see it in this room. I see it everywhere I go, in between national strategies and large coordination, and and then small-scale community development. I think we're misnaming the problem, right? If we want to maximize impact, particularly with WASH, we need national strategies. We need coordinating bodies. We need, I always say silos are the enemy. Whether that looks like a small community WASH water management committee that's interfaith, or if it looks like a national health board or a national council in which faith leaders and the Ministry of Health sits together. For me, if we want to maximize impact, we have to have conversations beyond just small-scale community development projects, particularly when it pertains to WASH. Thank you.
Ronald from the Christian.
Last comment, thank you.
Yeah, Ronald from the Christian Medical Association of India. We haven't heard anything from Asia, so I thought I will speak on behalf of Asia. Prior to my engagement with CMAI, I was with the Christian Conference of Asia, and we had a very successful model of having this interfaith platform, particularly with HIV. We had that at a regional level, but we understand that it works better at a national level. And every national level have an interfaith body. And we might not talk about technical things like WASH or HIV or other things like that. But if we bring them together, when we brought them together, we ensure that there is a faith leader as well as a medical personnel from each of those faiths to discuss the issue of HIV. That was very successful. It happens in all the country, in Cambodia, in Indonesia, in Timor-Leste, Malaysia, in Philippines, everywhere. It can happen in Thailand, India, and other places as well. So I think having that platform, maybe from the WHO, we involve UNAIDS, the regional body, in every of those meetings that we have, whether it's at the national level or whether it's at regional level. So likewise, WASH and HIV is a very integral part of that as well. So maybe there are ways of having that coordinated mechanism at the regional as well as national. Just want to share our experience. Thank you.
Thank you so much. Jean, the floor is yours again. Thank you all very much for taking part in this. Very grateful to all of you. Look forward to the rest of the time together.
Thank you so much, Mark, and thank you so much to all the panelists present and departed. That was an absolutely fantastic session. We heard about relatively new entrants into the world. We heard about how some of the folks who spoke are being beneficiaries of the work that has gone before from other religious communities. We heard concrete suggestions such as regional meetings, and possible meetings, further meetings hosted by the Muslim World League, all kinds of really exciting. We heard about the possibility of sharing assessment tools, and we actually didn't mention the idea of sharing training tools that Colin was attributed for. So marvelous stimulus, I think, to thinking about synergies. And thanks, Mark, for chairing a very good session. Before we break for tea, as Nakata calls it, I certainly will be having tea. Just a couple of things. First of all, to welcome again those who are participating online. We are live streaming again today, and we really welcome those who are participating with us online. We have a few people who came to us just for today, and we'd love it before we break if you wouldn't mind standing up and introducing yourselves. If you could raise your hands, the mics will come to you. Just a couple of people. Please raise your hands if you weren't with us yesterday. Oh, there we go. Thank you. Please, go ahead.
Hello, good morning. My name is José Luis Cobos. I'm from Spain. I'm the president of the International Council of Nurses. It's the organization that represents all nurses worldwide. It's 30 million of nurses, so a big organization. And I had the opportunity after lunch to talk about a little bit more about my organization and the contribution in this important project. Thank you very much.
Thank you. You're very welcome. Please.
Yeah.
Bonjour.
Good morning. I'm happy to be here with you this morning. I come from Mali. I am Dieudonné Arama, and I am diocesan coordinator of Caritas for the time being at interim. Previously, I worked as responsible for the Department of Social Development. In the framework of these activities, I work a lot in the WASH sector, especially with Caritas, Diocesan Caritas. Thank you very much. Thank you, and you are more than welcome.
I'm David Poinard, CEO of Veolia Foundation. I work for humanitarian and development aid and social inclusion and protection of environment and biodiversity all around the world with 220,000 people, 220,000 employees of Veolia to help you if you want. We work also on health with, we want to fight against cholera, for example, and other projects. And yes, I'm here. It's a pleasure to be here. Thank you, everybody.
Good. Thank you for coming. Anyone else? Great. Well, you're all very welcome. Just before, again, we break for tea, could I remind us all to use the QR code to go to the website that is supporting the meeting here, not only with the resources that will be available for going forward, but also, Maggie, thank you for mentioning it, for the record of the commitments and the progress notes that have been made by so many people who've attended here. We wanted to shortcut sort of the actual presentations and the updates and the progress. And so many of you have gone to great trouble to fill out quite detailed progress notes and commitments, and I commend them to you. If you scroll down on the website, you will come to the commitments. So just if you could put in a little bit of time there. And as we break, I'll turn to my fearless partner, John, for any logistical information.
Jean, thank you very much. And once again, welcome to our colleagues joining us online. They come, just for the record, from, you might have heard of some of these places, countries in Africa, Asia, Latin America, the Middle East, an unnamed Central Asian country, and with specific greetings from one member of parliament in Uganda. So this is a very popular setting here, Jean. Coffee, tea, snacks are ready. 11:10, Jean, back here at 11:08. Please and thank you.